Okay. Oh. Hi, Takashi.
Good evening. Good evening, John. Today is Russian neurosurgery.
Yeah, I don't know what's happened. Something's going on. I don't know what the heck's going on. Uh,
Oh, the
yeah, did you get in okay? No problem?
yes, I no problem. Zoom registration is available, but the time zone is different.
Yeah, I tell you, I've been trying to use meetings as well as Zoom,
Hmm.
regular Zoom,
Hmm.
and something's going on. It's just not working right.
Okay, and China. How about China? China neurosurgery is about it's okay.
Well, Nargiza, you get it. You get in
Hello.
without the code, right? Without the webinar ID.
Yes, I joined from my email access, not directly from WhatsApp.
Yeah,
Good afternoon, everyone.
yeah.
Hmm.
This is Takashi
Yeah.
Khan.
Thank you. I'm Dr. Kong. I'm from Tokyo, Japan. Nice to meet you.
Nice to meet you, Professor. I'm
He's
Dr. Nargiza. I'm from Uzbekistan, young neurosurgeon.
Uzbekistan. Okay, Uzbekistan.
Yes.
Tashkent?
Yes, I stay like 30 kilometers from Tashkent, but
Tashkent.
I don't
Okay.
stay in Uzbekistan. I mean, I study in different places. Right now, I'm in Istanbul.
Istanbul. Okay.
Mm.
So, under Uyghur tour and microanatomy, learning
No,
microanatomy,
I'm not under Yugur Ture. I am under Mehmet Özek. He's pediatric neurosurgeon. So
pediatric
I'm
neurosurgeon. Okay.
doing pediatric neurosurgery.
Okay. Thank you. Great. I'm working at Tokyo and Showa University and asking for neuro-oncology, malignant brain tumor.
Wow, great. Thank you.
Mm.
So
Thank
today
you.
you will be presenting, right? Or hosting?
No. I'm also a host and the panelist, and I'm looking for the time to begin. Which way to?
Mhm.
Well,
Okay.
Nargiza, we just had a Russian grand rounds and went really well. Interactive. We had some big neurosurgeons there. Now Takashi is hopefully will do the same thing in Japan when
Mm.
things settle down a little bit.
Great.
So he'd be your equivalent in Japan because
Mm.
our dream is the same: is to travel the world and to do neurosurgery
Yeah.
conferences.
Yeah.
Right,
Yeah. Yeah. Yeah.
Takashi? Right, Takashi?
Yeah.
I'll see you in
Uh,
Paris.
yeah. I'm traveling. Neurosurgical travel. The next month I go to Bali, Indonesia, for Asian
Oh wow!
neuro-oncology meeting, and
Is it?
in November I go to Vancouver for SNO, Society for Neuro-Oncology, to give a presentation.
Wow.
Oh, okay. Where are you
This
going?
is perfect.
Bali and Vancouver, and next year
Oh,
WNS. I'll attend to Chicago. Go to Chicago next May.
well, Vancouver is a wonderful place. I went to school
Uh,
there. I went to school there. It's the
oh,
far west of the continent. It's very rainy there. Rainy.
rainy, yes, and
Yeah,
November very cold, I think.
Yeah,
yeah.
it's
Well,
windy
very
and
cool.
cold there.
It's
So
not as cool as the rest of Canada.
Mhm.
It's on the ocean. It's moderated by the ocean. Uh,
Oh,
that's where Canadians go. They consider that their Florida,
Florida.
but
Yes.
it's not Florida. Not
Not,
warm like Florida.
uh, yeah, not different from Florida.
Yeah. Okay. I don't know what's going on here. We'll just
Okay.
hang out for a little bit. I
Yeah,
have a
I'm waiting for. Yeah, I'm waiting. Okay. So
yeah.
see you
Let
then.
me try to WhatsApp. That's where I usually reach Ben. Yeah, I asked someone from China to test it, and they could not sign in. Takashi, I've been trying to use the meet, there's two parts to Zoom. There's a webinar and there's a meeting.
Yeah.
Okay, the meeting it's a different interface. I think it's better. But however, ever since I started using it, Zoom has been acting really strange.
Yeah.
Really strange. It's been asking, Nagisa had asked for an ID. Another gentleman is that never did that before. So I'm just going back to webinars, strict webinars. That's it.
Quick one. Quick one.
Yeah, well, it's easier to use. I haven't heard from Ben. It's unusual. I don't know. Maybe there's because our internet went down in Miami. There was a storm here. Okay, let me try WhatsApp reach. Tell Nagisa where she should go in Japan. Under what cerebral vascular fellow? Takashi.
Yeah, there are several positions available according to the school. Not my school in Showa University. Then the vascular fellow and pediatric fellow. Sometimes several universities can
Provide this fellowship.
Yeah, do you have some? If you think so, I will give information because our university, Showa University, have very few pediatric neurosurgery programs. So we refer to other hospital,
Actually,
other national center.
During the COVID, I used to send a lot of messages to people and ask, like, will it be possible to come for the short period of time? So I texted to Fujita University, Kyoto University.
Fujita, Kyoto.
Yes.
Fujita, yes.
So I hope maybe for at least 3 weeks I will be able to come to Japan. Japan is in my list, and this is the best country in cerebral vascular. No doubt about that. So I mean, I have to go in to see the techniques. That's why it doesn't matter whether you will be perform it later on, but you have to see how it has to be done in a proper way. So that is my intention.
Okay. So pediatric program. So some national center and Kyoto University also. Professor Arakawa, a new professor, and pediatric program is about the national center or some children's hospital are available.
I just have sometimes, I text them. I find their website and Gmail address from official website, but I think better to write to direct message because whatever comes to from website, they are not available to answer. So I'll make some research about that.
Okay.
Yes.
Yeah, hopefully. So if you come to Japan, so visit Tokyo, so we can visit. We can see them. So in Tokyo, several meetings will be held in Yokohama. Neurosurgical national meeting will be held at the end of October in Yokohama.
This year or next year?
This year. Every year. So yeah, Japan Neurosurgical Conference will be in October. This year, Yokohama, and next year also Yokohama. Okay,
maybe I'll try for next year because this year.
Okay, yeah.
Will not be possible because October it's almost here.
Yeah, too close.
Yeah, too close.
Yeah. So I'm waiting for you. In Yokohama, in Tokyo, in Japan. There are many foreign people coming to Japan. So now it's crowded in Tokyo airport, but we are very excited to see many foreign people in Japan.
Yes, I do travel a lot and try to explore, you can read the articles, watch YouTube videos, but usually it is not enough. So
yeah.
I'm better to go and see and
Mm.
have this direct conversation. So
That's very important. So yeah,
Yeah.
my son likes Russia. My son visited Tashkent, and he really enjoyed the food. Samarkand, Tashkent, yes.
Food is nice.
My son really enjoyed Tashkent, Hyatt Regency lunchtime. Lamb, some meat,
Lamb.
lamb.
Okay. Okay.
Yeah.
Okay. Actually, the Uzbek food partially came from like proper South Asian countries. Something called, we have lagman, lamyan. It's long noodles with meat. That is actually came from Mongolia and then from China. It was migrating and settled down in Uzbekistan. So,
mixed culture, mixed food culture.
yeah,
Uzbekistan.
mixed culture.
Okay.
So something came from Europe, something from like proper South Asian countries.
Okay.
So yes.
Yeah, I'll just see. So really enjoyed.
Yeah, in January, I'm planning to come to India and I will be staying there. So yes, from India, it's easy travel around the Asian part. So I think by that time I will manage my trip to Japan.
Yeah.
That will be better.
Yeah, hopefully. So see you in Tokyo.
Thank you.
Yeah. So John, should we wait for the meeting or some reason?
Wait a few minutes because Sufinov may come. But I just talked to someone from Japan. They said they could not get in. And I'm going to translate what they said to me.
Okay.
So I think, you see, Google's making all these security changes. And you got to go through Google if you're going to televise because you have to use YouTube.
Okay.
And I tell you, it's very confusing. I think there's something screwed up in the security part. Because strange things are happening. And I'll show you actually. Let me translate this. Someone sent me something in Chinese. Okay, let me translate it to see what they say.
Okay, so yeah, I try to go to work, and today's my night shift in the hospital. But later, if the meeting will be held, so I will join again.
Oh man, it's sending them a weird question.
Okay.
Yeah, I'm gonna screen share what they're showing me. It's okay. Here's what the Chinese gentleman said he got as a message. You see it? You see it? See this? In other words, it's not working. So, yeah, we can wait. Well, you guys got in. That's strange. Did you have anything, you notice anything different, Nargiza? Now, usually you can get in without putting the code in, right?
Yes, I went to my Gmail messages and I entered from there without any problem.
So, did you get it from your smartphone or laptop?
Yes, from my iPhone. My laptop right now is on charge.
Okay, so usually you're on the smartphone now.
Yes.
And when you clicked on the link, it asked you for the ID
Meeting
number.
ID, yes, but then I went for Gmail messages. Directly from WhatsApp, usually it asks the email, this meeting ID. But when you go from Gmail And you already registered there. You just go for join the meeting.
Oh, I've got to understand that better because I think we're losing some people. Maybe I should be giving out the web ID.
Yes, if you put meeting ID, maybe people can.
Yeah, maybe they're
join
trying to
faster.
get it from the smartphone and they can't. First of all, it's hard to manipulate a smartphone. You got to copy and paste from another page. So I could see why people would say, the heck with that, man. Oh, man, this is not good for credibility. You know, I'm not going to use the breakout rooms for next weekend or the conference. It's just, it's causing too many problems. And it's screwing Zoom up because I'm having all kinds of problems with Zoom. I'm having problems logging in to Google. Google's very strange now because they have something called a screen share. You're going to log into that and it's going to send you a code. I mean, it's getting confusing. And I'm talking between someone's phone. Okay, there's been right now. Yeah, there's been now. Hello, Ben, can you hear me? Oh, good. Yeah, Zoom is acting crazy.
Yes. Yesterday we couldn't log on in another room. Yes.
Oh, so you couldn't get in?
Yes, I don't know why.
Okay, Wan Lee's here. Okay, he just got here. We'll start if the speaker comes, but so far a speaker hasn't come. Now, do you need the web ID of the meeting? Yeah, okay, let me send you another, I'm going to send you another on your WhatsApp.
We couldn't use WhatsApp.
Oh, not WhatsApp. I'm going to send you, okay. Here's another link I'm going to send.
Yeah, please add Mr. Lee. He is in charge of the broadcasting in WeChat.
You get that link? Try that link.
Okay.
Zoom and get the web ID. Yeah, I sent you the web ID number too. Did you get it, Ben? Wan Lee, how you doing? Are you there, Wan Lee? Are you there, Ben?
Yes, I'm here. Yeah. Actually, yeah, I got the right link from the email because you sent the early web link and the meeting ID is not work. But now
okay. Okay, Ben got in finally.
I just got the right.
Yes,
Hey, Ben, how you doing? Sorry about this.
Yeah.
I
Yeah,
think
I just got the right link.
Yeah, Zoom is acting crazy.
Yes.
Because I've been experimenting with doing, there's another type of webinar, it's a meeting. And it is different. I'm not doing it this one, but I've been experimenting with it because we have that big conference with Sam. But it's just, I think it's too much of a problem.
Yes.
It's causing problems like this.
Yes,
So
yes.
I'm going to go back to the webinar and not use the meeting. And I think we have our speaker here now. Hopefully. Have you checked with your, Dr. Sue? Dr. Sue, she can't get in either?
Yeah, we will try to connect. Just
Yeah,
a
we can
minute.
do it. We will have to,
Wait, let me do
yeah,
it.
I'm going back to, okay. Who's this guest? Okay. Well, do you have the speaker handy, Dr. Dia Sue?
Oh,
She, have
yeah. Let me
you
try
been in
to.
contact with her?
Okay.
Yeah, I've had a couple of people from China not say they can't get in. Okay. Okay, the link was the thing. Okay. Wan Lee, can you check with the speaker? The
Yeah,
DS?
yeah. I'm trying to connect.
Okay. We'll just hang tight. She must have had a hard time too. Yeah. And I'm going to give you the link, Wan Lee, of that's the link that Ben got in with, Wan Lee. I sent it to you. So if you could send it,
Okay.
if you send it to Dr. Sue, he got in that way.
Okay. Okay. Okay.
Here she is. Here she is. Excellent, excellent. At least we'll get one webinar done. Hello, Dia Sue. Dr. Sue, are you there?
Yeah, I'm here. Hello.
Yeah, we just had some technical issues. Are you ready to start?
Yeah, of course.
Okay, is your camera working okay?
Yeah, okay. I can start now?
Yeah, no, your camera's not working. I can't see you.
Okay. Wait a minute.
And Wan Lee, you're gonna, hi,
Okay.
Hi,
Hi.
Dr. Sue. Yeah,
Hi,
Wan
how-
Lee's gonna introduce you, okay?
Okay.
Okay, Wan Lee, are you there?
Yes. Okay.
Okay, here we go. 10, 9, 8, 7, 6, 5, 4, 3. Good morning from Miami Beach, Dr. John Bennett. We have another in the Chinese Journal neurosurgical meeting twice a month. And today we have a few speakers. One, Dia Su, a neurosurgeon from China. I'm going to let Wan Li, a cerebral vascular surgeon from Beijing, he's going to introduce her. Good day, Wan Li.
Yeah, yeah. Good evening. Good morning, everyone. Okay, yeah. This is Yuan Li from Chinese Neurosurgical Journal, and thank you, John and Doctor. Today, Dr. Bing Xu from Shanghai Huashan Hospital and me, Yuan Li Zhao from Beijing Tiantan Hospital will moderate this bi-weekly webinar from Chinese Neurosurgical Journal. And today, we invite Dr. Su, the lady neurosurgeon from Xinhua Hospital of Dalian Medical University, to give a speech about it's about peripheral nerve neurosurgery. Okay, so please, Dr. Su, you can start your presentation. Thank you.
Okay, thank you very much. Okay, hello everyone. My name is Dia Su. I'm from the Dalian University affiliated Xinhua Hospital. It's a great honor to be here today to share with you the research of facial nerve repair. Facial nerve injury and repair is a key issue of multidisciplinary attention. This includes plastic surgery, neurosurgery, neurology, and Chinese traditional medicine, and so on. Okay, first of all, let's review the anatomy of the facial nerve. Facial nerve is the seventh cranial nerve, which is composed of sensory and motor fibers. These two fibers form the motor and sensory roots. The motor root constitutes the root trunk of the facial nerve, and the sensory root is called the intermediate nerve. The cranial alignment of the facial nerve is like the picture shows. It starts from the lower part of the pons, come to the facial nucleus, and then come to the cerebellum angle. Here, the facial nerve runs parallel to the auditory nerve, then come to the facial nerve canal. At last, exit the skull through the stylomated foramen. Then, next, let's review the anatomy of the peripheral segment of the facial nerve. After exit from the stylomated foramen, it comes into the parotid gland and quickly separated to the temporal trunk and the cervical facial trunk. The temporal trunk divided into two branches, and they are the temporal and the zygomatic. The cervical facial trunk divided into three branches. They are buccal, mandibular, and cervical. Here like this. And this is the second part. We will talk about the causes of the facial paralysis. The etiology of facial nerve damage is complex and diverse. According to the different locations of injuries, the etiology can be divided into two major characters. First of all, we talk about the central facial paralysis. Central facial paralysis refers to the injury occurring to the segment above the facial nucleus. The common causes is about cerebral vascular disease. The symptom is that the facial expression above the eyebrow was normal, but the facial paralyzed below the eyebrow. And the other category is peripheral facial paralysis. When the location of injury is below the facial nucleus, the patient presents with global paralysis of the contralateral side. Common causes of the peripheral facial paralysis is compression of tumor, facial nerve tumor, viral infections, and trauma, or some other reasons. And next, we will talk about the tonight's focus part, the treatment of facial injury. And the treatment of the central facial paralysis is mainly by improving the loss of blood flow. The main treatment method of neurology are intervention and use some drugs. Neurosurgery is mainly improved by operation, but sometimes the effect is general. Peripheral facial paralysis is classified into about 3 types according to its etiology. First one is compression of tumor. The objective of treatment is to relieve the nerve compression by the tumor. There will be 3 kinds of results after the tumor resection. The first one, and is the best one, the facial nerve recovered immediately after the resection of the tumor. And second one, sometimes facial nerve recovered after 3 or 6 months later. And sometimes we will make the worst one. The facial nerve could not recover without intervention. At this time, we need nerve repair surgery to help the functional recovery of the facial nerve. When the time of facial nerve injury is less than 2 years, we have 3 traditional repair options. They are facial nerve masseter nerve anastomosis, and facial nerve hypoglossal nerve anastomosis, and transfacial nerve anastomosis. First, I will introduce the facial nerve and masseter nerve anastomosis first. A portion of the masseter muscle was sutured to the injured facial nerve. The 2 adjacent nerves didn't require a nerve graft to cooperate. After a recovery period about 6 months, the patient can achieve facial movement through the masseter muscle first. Look at the picture. Here is a masseter nerve, and here is a facial nerve. We suture them together, and after a recovery time, we will got the facial muscle movement by the bite movement. And the second is facial nerve hypoglossal nerve anastomosis. The principle of the operation was similar to the previous one. The facial nerve was replaced through the hypoglossal nerve. However, the hypoglossal nerve is far from the facial nerve, so it needs the cooperation of the nerve graft. Here is the nerve graft. The nerve graft is usually the sural nerve. It's accessory nerve of the lower limbs, which is not very important for our body. After the recovery period, the patient can achieve facial movement by the tongue force. And which of the 2 surgical we talked about before is better? Now it's controversial, but the next surgical procedure is recognized as the best way. That is the cross-face nerve graft. This surgery needs 2 steps. First one, the healthy facial nerve was anastomosed with the graft nerve for this part. And the prepared nerve was buried in a tunnel under the skin. After about 6 to 12 months, the facial nerve fibers grow into the nerve graft. And the second part of the anastomosis was performed between the transplanted nerve and the injured facial nerve. The result can be seen after another 6 months. Although this operation takes a very long time, but it can achieve a satisfactory facial nerve functional. Facial nerve repair with one side to another side can achieve a more symmetrical and aesthetic facial expression. This kind of movement will be more reasonable for our face. But if the duration of facial nerve injury is more than 2 years, recovery of the neurological functional is difficult. Muscle controlled by denervation also atrophy. So we need another treatment to help this kind of patient. So the transplantation of the vascularized gracilis muscle is needed. We sutured the muscle connected vessels to the facial arteries and veins. We suture the muscle connected nerve to the contralateral nerve. So we have a complete system of blood vessels, nerves, and muscles. The operation is completed, and there is a possibility that the muscle will not survive. But if the muscle survives, the outcomes of the operation will be very good. So we can see from the picture, here is the muscle with the nerve, the veins, and we move the muscle to the face and suture the veins and the nerve to another side of the face. There is another kind of paralysis, which is caused by the Bell's facial paralysis or Hunter syndrome. Neurology should be considered first for this kind of patients. Antiviral therapy and hormone therapy is effective to most of patients, but if the nerve becomes too swollen or jammed, we will need to do the surgery. The surgery is called facial nerve depression. The principle of the operation is very simple. First, the facial nerve canal was to open and the epidural was open too. The purpose is to relieve the swelling and replace the pressure due to the edema. And the last kind of paralysis is caused by trauma. The objective of treatment is to maintain the continuity of the facial nerve. The method of the treatment is very easy, just to do the nerve anastomosis. The result of the surgery depends on the time for the injury. The prognosis is better after operation as soon as possible. Here, we can see the picture shows a patient with a knife injury. The branches of the facial nerve were severed, and we use the great auricular nerve here, and the severed facial nerve was successfully repaired. Here is the facial nerve. It was severed, and we use the graft to help the nerve. After the recovery, we can see the patient has a good functional. And the next part is about rehabilitation therapy for the facial nerve repair. In addition to surgical treatment, another objective treatment can also help the recovery of the facial nerve. Electrical stimulation therapy. One side, the electrical current is used to unblock the nerve conduction pathway, and the other side, it can also prevent muscle atrophy. And next is the TMS. TMS is another way to help the facial repair. It makes the magnetic field to the electric field, and the electric current can stimulate the cerebral cortex. Now, the TMS is very popular for the patient. And the last one is the most important one. It's to do the functional exercise. Patient with surgical or non-surgical can all need to do the practice. It's better to face the mirror when they do the exercise because it can improve the symmetry of the bilateral side. And at last, if patients have a high requirement for the static facial appearance, facial suspension can be considered for improvement. The anatomy liked the dropping face like a rope, but if we do this kind of surgical, we need to talk about the patient, tell them that this surgical can only improve the facial asymmetry, but no movement, but no functional improved. So, okay, that's all I have talked to everybody to share with you about the facial paralysis and the injury and the treatment today. And thanks very much.
Oh, I'm sorry. Yeah, thank you very much, Doc. It was an excellent presentation, and thank you for taking the time. Do we have any comments or questions from any of the panelists? Hello, Albert. Welcome.
Yeah. It's really nice presentation. I really where from the speaker? From which country speaker?
Oh, no, not yet, Albert. We're gonna have a few questions here first. I don't know, Ben, do you have any comments or questions? Can you hear me, Ben?
Yes, John. Yeah, very nice presentation. And actually, this is also, I think, a quite new treatment. I didn't do this kind of treatment yet, so I have no experience on this side.
I was to study about the neurosurgery, but now I'm a plastic surgery doctor. So some kind of the surgery I have read it from the plastic surgery books. So I give it into the PPT.
Great.
Okay.
Okay, Takashi, do you have any comments or anything you'd like to add? You're muted, Takashi.
Thank you for the nice presentation. I'm Dr. Kong from Tokyo, Japan. I'm not familiar with the facial nerve itself, but facial nerve pulse is very important to after the surgery. So your lecture is very informative, and I learned a lot about the microanatomy of facial nerve. Thank you so much.
Okay, thank you very much.
Yeah, actually, Dr. Su, I have a question about you mentioned about TMS, so I want to know a little bit more about what kind of patient with facial nerve injury will be benefit from TMS treatment.
Okay, actually, any kind of patient with facial injury all can do this kind of therapy because if when they do surgery or not do surgery, the cortex can all get stimulate from the TMS.
So which part of the cortex? Are there any special area in the brain?
Yes, it's very complicated. I can't introduce very details. There are too many parts of the stimulate point around our cortex.
Okay.
Oh,
Okay.
yes.
Okay. Thank you. Thank you again.
Thank you very much.
Okay. Okay, we're gonna move on. Thank you, Dr. Su. And we'll see you in the future. Okay, Ben, do you want to introduce Dr. Sufianov? You probably know him.
Yes. Professor Sofianov is my good friend, and he is a very famous Russian neurosurgeon, and he is the head of the second largest neurosurgical center in Russia. And he is a very famous for his neuroanatomy course. I think every two months he had this kind of course, and his endoscope combined exoscope surgery is very unique and very experienced. Now let's invite the Professor Sofianov.
Okay, possible?
Professor, yeah.
Thank you.
Possible. Okay.
Great.
Professor Shu, thank you very much. Thanks a lot for introducing me for audience. And I want to say also thank you to Bennett, just to give our possibility to share our experience about this kind of surgery. Можно включить это? Okay, it's possible to see my screen?
Perfect.
Yeah, чуть-чуть укинь, кипника. Okay, and today I want to say about our exoendoscopic surgical experience about surgical treatment of craniopharyngioma in children. At first, I want to introduce myself for audience because it's a China audience mainly, and I am from Federal Center of Neurosurgery from Russia, and Tyumen just localized, just middle point of the Ural Mountains of the Russia. You see, just middle point of the Russia. This is beautiful city. Еще раз, секундочку. Можно убрать эти штучки все пока? And our Federal Center is Neurosurgery is one of the biggest center in the Russia, one of the biggest, because of course all people know Burdenk and other center, but we are the new, just only 10 years, and we have all kinds of modern equipment. For example, we have 7 modern operation rooms, including 3D hybrid ICT operation room. And near the totally, we have more than 70,000 neurosurgical cases and more than 5,000 neurosurgical cases per year. And all these elective cases done in our Federal Center of Neurosurgical. All totally, we have 5 neurosurgical departments: pediatric, neurovascular, spine, neuro-oncology, function, and we covered all files of current neurosurgery. And you see our hybrid ICT operation room as a full CT by the rails go during the surgery is possible. Also, we have good equipment like laser, especially for the it's very important for the minimally invasive neurosurgery. And also, we have experience by 3D exoscope. Also, you see our exoscope in the inside of the operation room. Now I start to say some words about the craniopharyngioma. Craniopharyngioma is a rare benign tumor of the central nervous system. And the incidence is two cases per million persons per year, generally. It's generally considered as a pediatric disease, as you see on the slide. For our presentation, I use QCT classification. You see on the slide the Q-type, S-type, Q-type, S-type, and T-type. And this is T-type, S-type of craniofibroma, and Q-type. So T-type, this one, is arised from the residual Redcase putsch precursor cells in the top of the pars tuberales, mainly extending upward. You see on this slide, mainly extend upward. C-type arises from middle or inferior segment of the stack. You see, this is the classification of the stack. So this is a C-type. It's from this point. And the Q-type arises from the subdiaphragmatic intracellular space from this point mainly. And you see this kind of tumor. So our surgical treatment of craniofibroma, we divide as usual on the three part. One part is if you have cystic part of the tumor, and if the cystic part larger than solid part, we first step we use Ommaya reservoir surgery. Second is the endoscopic transnasal surgery, if you have good conditions for the endoscopic surgery. And also we have big tumors, multicystic tumors, difficult tumors, maybe not soft tumors for the suction. We have a microsurgical technique. Now in these days, exoscopic surgery. So if we put Ommaya reservoir as a first step, when we see if we have further indication for the future removal of the tumor, so we use endoscopic or microscopic technique. If the cystic part is stable, so we inject drugs inside of the tumor. So this kind of Ommaya reservoir we use standardly. Is a standard device. And again, if we, in case of craniofibroma with large cystic components, in order to decompress neurovascular structure, especially in difficult condition of the patients, we use the implantation of the Ommaya reservoir. You see the Ommaya reservoir inside of the cystic. And usually we use like a first stage of the neurosurgical treatment. You see. Our experience of the treating cystic craniofibroma by insertion of the Ommaya reservoir system in children. So totally we have experience of the 10 cases now, and the average age is near the 8 years old. And insertion of Ommaya reservoir and further removing of the craniopharyngoma, 6 cases, and only insertion Ommaya reservoir and further systematic drainage of the cyst by puncture, 4 cases. So in these 6 cases, microsurgical removing was done in 3 cases and endoscopic transnasal in 3 cases. Total removing was in 4 cases, near the 70%, and subtotal removing in 30%. What about the puncture of the Ommaya reservoir? So average cystic drainage by the puncture frequency per year was mediumly 6 per year, and the volume of the drainage for one session is near the 10 milliliters. So now I want to show some cases. This is the case 1 about a patient with 6 years old. The standard typical situation in this kind of lesions. And this is the MRI before. You see the big cystic part. And type Q. And this is our surgery. First step is this is equipment of our endoscopic operation room for the child. The skins marks, and this is the entry point. Preparing, because a small baby, so very careful. Bleeding stop, even from skin. Monopolar cautery we use. Now we create some pocket for the amide reservoir by the scissors usually. Second one, we open the skin of the bone. Now create the bar hole. And second was under ultrasound navigation possibility. We try to go inside of the ventricular system by the endoscope. This is a super thin endoscope. And now inside of the ventricle, and because it's very narrow, so we put inside least small solution. And now we see the foramen Monroe blocked by craniopharyngioma. It's a typical VU. You see thalamus striate, septal vein, thalamus striate vein here, choroid plexus. This is Monroe, and this is the tumor cyst. And after we put inside of the endoscope the laser. And now open fenestrate by laser by vaporization of the cyst wall, very precisely, and without contact of the wall. You see, vaporization creates a fenestration in the upper polus of the cyst. And it is very important to create the very precise size of the vaporization. Not necessarily drainage contents of the cyst inside of the ventricular system. So we go inside of the cyst by the endoscope and then put out the contents of the cyst and wash volume of the cyst by solution by the saline. And you see, repeatedly wash contents of the cyst before we clearly visualize contents of the inside of the cyst. And after, it's possible to go to the bottom of the cyst, because you visualize now very well all the mark inside of the cyst, and choose the place to put the catheter of the amide reservoir for effective drainage. You put the good place for ventricular catheter by under control of your own eyes. It's very important. We just choose the place by endoscope. You see the endoscope stylet, the technique. Technique is endoscope stylet. We use endoscope like a stylet, and then we remove the endoscope simply. And the catheter stay in the right place. Now put the reservoir for the pocket, which we create before, on the skin. And suturing the skin and aponeurosis above. Very simple and very effective technology. And very safe, because all steps done under the visual control of the surgeon's eyes. So you see, we put a ventricular catheter inside. This is before, this is after. In very correct place. Even contents from the bottom of the cyst drainage through the to the amide reservoir. Possible, aspirate. This is another case. This is a multicystic craniopharyngioma. You see, one compartment and the second compartment, different contents. You see, so why we decide to put in each compartments one catheter. So one catheter and second catheter for each for each compartments of the cyst. This is before. This is after. One catheter, second catheter. You see the step by step. The amide reservoir with two catheters. You see intraoperatively, and this is a 3D CT scan. Another surgical great possibility is endoscopic transnasal surgery. Is one of the best options for this kind of pathology in the child, but sometimes we have some limitations. But we discuss about this later, a little bit later. This is our experience about this. So type 2 is never we have experience like this. Only type C and only type Q. Neither 50 to 50. Mostly is the in children is mostly type Q more frequently. And in these cases, endoscopic removing, you see, totally removing is 5 and subtotal removing 2. So mostly endoscopically is possible total removing this kind of pathology. This is step by step about this kind of surgery. Is the standard typical endoscopic endonasal approach. You see the anatomical landmark. Adrenalization of the cavity of the nose, first one, middle turbinectomy, because this is a big size, big volume surgery, so why we need space, so why we remove middle turbine near the every cases. This is the main anatomy inside of the sinus. You see optic nerve, chiasm, optic carotid recess, pituitary gland, ICA, clivus, and so on. Next step. And also, I want to say what it's very important to understand. Child's time is not so many limitation for this kind of surgery because intercarotid distance is established in early age and does not change significantly. You see, and sphenoid sinus also primatization also give possibility. You see, even from 6 years to this kind of surgery. Even in 3 years, we have the sphenoid sinus. So also not so many limits sometimes. Only sometimes the size of the nose give some trouble for the surgeon. One of the most important is how you close your surgeries after surgery. So pediculate nasoseptal flap technology is very important, and you must understand this technology and used in every kind of this kind of surgery. You see the Haddad flaps. preparing before surgery, like this. This is the scheme, standard scheme. Standard flap, large flap, bottom, and extended flap. Go to the lateral wall. This is our case about this kind of surgery. The male, 6 years old, typical complaints from age of the 3 years old. And this is MRI before. You see big cystic compartments. So why, as first step, we introduce Amaya reservoir, and this is surgery after introduction of the treatment by the Amaya reservoir. It's not enough, so why we decide second step, the transnasal endoscopic removal of the tumor. This is tumor inside the sphenoid sinus. We open anterior wall of the dura. Remove some remnants of the bone, just enlarge the surgical window. It is very important. Large surgical window. It must be not narrow. If necessary, additionally drill above and bottom and lateral bone of the surgical window. And after, it's a typical step. We open the cyst, and you see the Amaya reservoir drain inside of the cyst. It's, you see, very correct position of the Amaya reservoir. Drains completely all cyst from bottom to up. And after start to dissect. If necessary, you must open even more the up to the chiasm, suturing the leaf of the dura, and this maneuver give us possibility to dissect more precisely, and you see more freedom, and this is give us possibility to dissect very precisely, bimanually. This is a chiasm very well, artery, main artery, and it's possible very gently to dissect from very critical structure of the bottom of the third ventricle. You use possible to use all kinds of instrument, even scissors, just to dissect, precisely dissect craniopharyngioma walls from the bottom of the third ventricle. You see the mammillary body very well after dissection. And in this kind is a total removing. Mammillary body, third ventricle opened. Diliquis membrane here. This is anatomy inside of the third ventricle. Choroid plexus, foramen Monro, both foramen Monro. And this is the closing of the defect of the dura. Spongastan. Fat. So closing is very important again. Fat. Suturing of the fascia lata above the fat. You see the suturing. And after, put the spongastan, surgery cells above the fascia lata. And then last step is you put the flap above. Surgical fibrillator, just a fixed flap on the place, and fibrin glue, the last stage. This is after operation. This is a very good nasoseptal flap. The second case is the male, 15 years old, also typical standard complaints and status, bitemporal hemianapsia and so on, atrophy of the optic nerves on both eyes, and so on. This is MRI before, type Q, and this is the case. Also, no cystic compartment. So why, as first step, is endoscopy and the nasal surgery. Again, large surgical corridor. You see, above, bottom, lateral. So enlarging corridor compared to the standard adenoma. Open the dura from the anterior part, and now start to dissect the tumor from inside of the teresurgical. Again, because the big corridor, it's possible to see all landmark inside the brain. You see very well main arteries, very important neurovascular structures, and also the big corridor give to us possibility very precise dissection, even from stack, as you see before, from arteries, as you see. This is A1, A2, communicating artery, for example, chiasm. So a lot of very important structure, but our corridor, surgical corridor, give us possibility. Sometimes blunt, sometimes scissors. You see, we use just to remove part by part. This very difficult, very adherent tumors tissue. Bimanual. This section is bimanual. It's very important because two nostrils we use. And this is view after the tumor removal. You see the very good stack. Chiasm, third ventricle, artery, A1, A2, communicating artery, third ventricle. So all structure is safe after dissection. This is after surgery. This is very good nasoseptal flap and total removing of the tumor. No leakage. This is five cases. Our cases, male, 13 years old, also typical complaint, also hemianapsia and so on. But this is a big cystic compartment. So why first step we use a MI reservoir installation. You see the ventricular catheter inside of the cystic compartment. And then, because it's not enough, so why we decide second step is endoscopic removing of the tumor. Also, typical big corridor, you see, a lot of drilling before, just to open dura. Typical cutting of the dura, like a Mercedes sign. And then we start, then put two suturing just to open the surgical window. It's very useful for the surgery, and after we start to dissect the main part of the first one from the cystic wall. You see the very good correction of the drain of the from the Amaya reservoir. Big volume of the cyst. We start on dissection, removing. But in this situation, very adherent structure. So some piece we stayed on the place, not removing. You see the catheter from the Amaya, and now we close the situation. So fat, we put fat inside of the tumor's bed. Start to suture the dura above, and so on. This is also good, very good nasal fat, no liquid air, no CSF leakage. Also, near total is removing. This is the fat inside. This is nasal fat 4 months post-operatively. It's a very good surviving of the flat. This is on the MRI. This is endoscopic picture. So next, on the last stage, we use sometimes in the microsurgical exoscopic technology also is possible. So in this slide, you see the evolution of intraoperative imaging devices in neurosurgery. So first ones on the loop, the simple microscope, very good microscopes. Sorry, what we use now, but next step, and this is the future, I believe, this is the exoscope devices. This slide shows the evolution in our center of the optical device. So this is typical operation room for the exoscopic surgery. You see the exoscope, lot of monitoring about 4K and so on. And very important new arm, because the mobility of the scope is very important during this kind of surgery, because it's not easy surgery. This is a scheme of the surgical team. First surgeon, first assistant, second assistant on the pilot. Pilot is as a device for the moving of the exoscope. And this is our experience about the microsurgical treatment. Children is total 18, but microsurgical 11. From this 11, total 10 and subtotal 1. This is about children's surgery. What kind of approach we use? Frontal, bifrontal, orbital, zygomatic, transbasal, and now supraorbital eyebrow keyhole approach also with orbital osteotomy we use in 4 cases. The case report about our technology. These patients hospitalized in our clinic in very critical conditions. So gradual deterioration, and 16 days before hospitalization, endoscopic fenestration of the cyst part of tumors done. You see the MRI before surgery. It's really difficult case, very large, and a lot of vessels inside, and completely fill the third ventricle. And this is blocked Monroe, no solid compartment. So I only microsurgical removing, and the not, I think before operation it's not possible to suction, so it's a hard tissue. So why we decide operate by microsurgical exoscopic technology 3D. This is keyhole supraorbital approach. It's only 3 centimeters, near the 3 centimeters only. Minimally invasive because this child come to our hospital in very difficult, in very severe conditions. So I decide to operate by the minimally invasive approach, keyhole approach from the supraorbital direction. Step by step. Also orbital, but also remove, just to give more freedom during the surgical removal of the tumor. Ultrasound knife we use for this kind of approach. Now we open the dura. Now we go inside of the intracranial cavity, and you see the optic nerve now very well. Drainage the CSF. Open the arachnoid and start to drainage, aspirate the CSF. And you see the optic chiasm. It's very short optics. Also difficult for surgeon. Lamina terminalis open. You see a lot of very important landmark inside. This internal carotid with the optic nerve. Optic nerve, chiasm. A1. Lamina terminalis. This is craniopharyngeal part. So we use lot of windows just to access to this kind of tumor. Interoptic windows, for example, optica carotid windows, lamina terminalis, you see windows, and so on. Because tumor is very big and very hard to remove. You see all approaches for the tumor we use. Not only one way. Optical carotid also, for example. Lamina terminalis, for example. Interoptic, for example, and so on. This is after operation, before, and this is after, near the total, maybe total removing of the tumor. So why advantage of 3D exoscopy in neurosurgery? We estimate like ergonomic comfort for the surgeon, last of the having of the whole uncomfortable posture with the operating microscope, and the ability to have a relaxed posture with the horizontal gaze versus flexed head and neck position with the operating microscope. First surgical assistant being able to comfortably assist during the procedure, high degree of the depth perception, doesn't consume a large footprint of operating space, and educational and training opportunities for the operating room staff, residents, and students also very important. Ability to see entire surgical field and rapidly switch from micro to micro vision. Ability for the scrap nursing to participate more activity in procedures. LED-based illumination generates less heat when operating microscope with the halogen lighting. It's very important for the surgery. High level visualization by the 4K high definition is also very important, especially in tumor surgery. And as the scope is distant from the operative field, always the better visualization during the procedure. And it is very efficient to use, for example, some long instruments. Lack of need of cleaning the lens from the fogging. And I think one of the most also important, especially for surgeons who operate a lot of surgeries per day, we must protect our eyes. So why less excessive harmful light exposure on our surgical eyes is very important also. Not only save the patient's life, also we must save our surgical conditions and eyes. Of course, 3D scope nowadays have some limitations. You see on the slide, but I hope the possibility of the 3D exoscope must be improved rapidly or to the future. And not only in the treatment of the craniopharyngioma, but also in neurosurgery, the exoscope is the future. I believe in this position. This is a take-home message on the slide. Thank you for your attention. Thank you. Some
Thank
questions?
you, Professor Sofyanov. Very nice presentation. And I agree with you that I also tried some exoscope to perform some micro.
Yeah, bypass. For bypass is excellent. For bypass is excellent. Yeah.
Yes.
Because not necessarily moving a lot of like
Yes.
in the tumor surgery.
Just as you mentioned that the assistant can see more clearly. Yeah.
Yeah, of course. So bypass surgery nowadays is one of the best device. But it is necessary another presentation. Not possible in one presentation. So I agree with you completely. Thank you.
Thank you very much. I have a few questions to Dr. Alberta Kramovic. First of all, thank you very much to being here. And I totally agree. As being a student of Professor Akcherian, I want to say that exoscope, it's a future, not only future, it's already present. And we have, as a young neurosurgeons, we have to use it. We have to know how to work with that. I have the questions regarding the closure with fascia, lata, fat, and Haddad flap. Professor, do you use every time autograft, or you prefer sometimes artificial graft for closing?
No, artificial is very rare. If possible, use
autograft. The second question is, I do understand that the type of craniopharyngioma decides what approach we actually use. What tool? I mean, endoscopic or exoscopic. But when it comes to very small child, like 3 or 4 years old, And we know that paranasal sinuses and cavities have already very small size. Can it come as a contraindication for endoscopic approach?
Of course, sometimes, but mainly in mainly cases started from 3 or 4, 5 years. No limitation.
No limitation. Okay.
Because I have one slide about the artery and about the size of the sinus, and you see during the year, so mainly from 3-6 years is no limitations. Possible.
Okay, thank you so much. Do you keep external ventricular drainage after surgery when patient has hydrocephalus, or after removing the tumor, you just close the?
It depends from the surgery. If all procedures, all steps is okay, you remove totally, open the third ventricle, for example, Monroe, so not necessary. If something in your situation is wrong, remnants blocked and so on, and we see what's happened. If a lot of blood inside, so drainage. If no blood, so mostly useful as a VP shunt, for example, or maybe septostomy VP shunt, and a lot of variation. It depends from personal situation inside of the surgical files. Yeah.
Thank you. Спасибо. Thank you so much.
Well, you know, Dr. Sufinov, for Nargiza just put together a Russian neurosurgery conference earlier in the day. I didn't want to bother you with it because I know you're busy, you're traveling, etc. But you'll be seeing Nargiza around if you haven't already.
We're looking forward to seeing Professor Sufianov on Russian neurosurgical grand rounds. You are
of course, but little bit busy now, so maybe next time.
Yeah,
whenever
sure.
we are.
Okay. Maybe not only me, maybe my staff also.
Yeah, definitely. Most welcome. Just give the details of your stuff and I will call
For example, maybe cranial synostosis surgery, we have a lot of experience in the open.
Great. I will contact Alia and
Okay.
Thank you.
Okay, very good. I think, any more closing questions or comments from the panelists? Ben, are you there?
Yes.
Yeah, I'd like to thank Ben for being patient. We had a little technical issues here. And thank you, Dr. Sofinov, for making the time. And we look forward to seeing you in the future.
Professor Binshu, I wait you in our workshop in October.
Yes.
Yeah, okay.
Yes. Okay.
I hope.
Thank you.
Personally.
Okay.
Thank you, me.
Okay.
Okay.
Thank you, everybody.
Thank you,
We'll see
John.
in 2 weeks. Thanks a lot, Ben.
Yes.
Bye.
Thank you, John.
Okay. I thought that was great, Ben. I thought we were going to lose that this week.
Yeah.
But it's like neurosurgery.
Thank you.
Sometimes you gotta stay calm and don't get too flustered. But thank you very much. And
Tonight we have another webinar, but one of our Chinese speaker couldn't log on, and I don't know why. So just as you mentioned, Zoom has some problem recently.
yeah, I don't know what happens in China, especially. There was another gentleman trying to log in now, and I was trying to lead him through, sending him links like I sent you. But I'm going to follow up with him, see what happens.
Yeah.
But we'll fix it. It's going very well. I'm very happy.
Okay. Thank you so much.
Thank you, Professor.
Hey, Nagiza, thank you. Dr. Sufinov. Takashi. All right.
Bye-bye.
Thank you so much.